Professor Ahmed Halawa, things which is probably no one mentioned it in the morning. He is not only transplant surgeon, he is also a physician, he is a nephrologist, immunologist. So, and his contribution to the field of the nephrology is excellent, and he tried to help so many people in our area in the Middle East. Prof. Halawa, I think everyone know him very well now, and he is welcoming any connection with him in the future regarding teaching, consultation, or anything. Am I right?
Absolutely.
He is going to speak about challenges in transplantations. Please, Prof. Ahmed.
Thank you very much, Professor Faisal Shaheen, for this nice introduction, and I'm very grateful for your invitation, and it's lovely to be with my friends and colleagues and brothers and sisters in the lovely city of a wonderful state of Oman. Hopefully you have a good lunch, because I'm going to wake you up and shake you, to interact with me again. Feel free to make any comments. If you are not happy with the management plan, just let me know and we can have a chat. Fine. Do you mind, Dr. Ahmed, just shut the door, please? Okay. Yeah. Fine. So, disclaimer, I don't have any conflict of interest. These are real-life clinical scenarios modified a bit to hide patient identifiable information, because it's illegal to disclose any identifiable information. So the first case is a very challenging case. So we've been offered a donor, 72 years old, DBD, donation after brainstem death, who suffered from hypoxic brain damage secondary to unwitnessed cardiac arrest. Estimated downtime, 30 to 40 minutes. After resuscitation, serum creatinine was 130 micromole per liter. Urine output last hour, 20 mL. Last 24 hours, 1.1 liter over the last 24 hours. As you see, is an elderly donor, 72 years old. Also, acute kidney injury. The allocation system, because the allocation system in the UK is a fair system, but you have to think, because the computer does not think for you. You have to make a decision based on the allocation system. Even you can reject the offer. The computer cannot do the transplant for you. If any complications, it's your complications. If any complaint and litigations will be against you, not against the computer. So the donor was offered to a 21 years old female on hemodialysis for the last 7 years, highly sensitized. The CPRA is 92% due to pregnancy and blood transfusion. Full house matched kidney. Negative flow cytometry score match. She's running out of access. If you see this lady, she got puffed face, tubular vena cava obstruction. So her lifespan is quite short. Journey in life will be quite shortened because of lack of access. Will you accept this offer for this miserable patient? Yes.
Yes.
Yes. Who said yes? Who said no? Yes, Ahmed. Yeah. Fine. But the question is, yes, we need to transplant this lady because running out of access, highly sensitized. This is a better match that you will ever get, full house match. But how would you do this transplant? Kidney came from a 71 years old, acute kidney injury. Any idea? Excellent. Yes. So you need to maximize the nephron mass. Is an elderly donor, acute kidney injury, into a young lady. So dual kidney transplant, and you see this is a McFree scan of the dual kidney transplant, both one on top of each other. The top one into the IVC and the water, the bottom one into the common iliac vessels. It's quite challenging operation, it takes around 5 to 6 hours, but successful and still working. I don't know what happens if this kidney fails. Fine. So another challenging scenario which hit the whole UK, and we need to think together, and we should learn from this message. You offer the kidney from a 39-year-old DBD donor who died of suspected meningitis, but no confirmation. He presented with loss of consciousness, neck rigidity. They thought it could be meningitis. No confirmation, no lumbar puncture. He got excellent kidney function, no significant past medical history, fit and well. This patient was a farmer, manual worker. Admitted to the ITU, intubated. This offer was for any recipient. Will you accept this donor? Excellent kidney function, young, 39 years old, no past medical history of any illnesses, manual worker. You can say yes, you can say no. Yes or no? Yes.
No.
No. There's no time, because once diagnosed brain death, we have to proceed with the donation. Investigations, if they are dead lumbar puncture, will come back later after donation, or even after transplantation, because you need to culture 48 hours. Excellent. Yes, 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 yes. Fine. So will you accept?
Well, I will accept, of course. I will not disregard any sort of an organ that's relatively might be used. However, then you have to inform the donor. You have to choose the donor. The donor has to be, the recipient, sorry, has to be a bit older age. Cannot be young, but then that'll be more traumatic, not only from a physician point of view, but even politically, economically, and so on and forth.
Yeah, thank you very much, Isa, for this answer. But here is suspected meningitis, not confirmed. Could be anything else?
Could be meningitis. Well, you said he's a farmer, and the specific issue might be related to United Kingdom as far as the farming.
No, I mean, could be farmer anywhere.
He has no travel abroad. Has he traveled abroad? Recent travel abroad?
No travel abroad.
And then should be very limited sort of causes of meningitis, if at all, from United Kingdom. That might be transmissible.
Fine. Because, the cause of death was unknown, no confirmation, we didn't take the kidneys. These organs, actually it was for multi-organs, declined by most of the centers, except one center, who accepted to transplant these kidneys. Actually, we have broken the rule. Which rule number one in cadaveric transplantation, deceased donor transplantation, is a known cause of death. So this is not a known cause of death. You know what happened?
Prof. Halawa, you allow me, if such patient with organs coming from suspicious case of meningitis, kidney can stay outside in perfusion machine for 72 hours. Why you didn't take other investigations, be sure either there is meningitis or not, and the kidney will be weighed and...
Well, what they did is lumbar puncture, and lumbar puncture came back negative. So it's still, and symptoms and signs of meningitis.
So So it should be deferred.
Lumbar puncture was negative, and there's a clear evidence, clinical evidence of meningitis. Let us learn from this, because I learned a lot from this. And I was quite lucky to reject this kidney, because if I'm not sure, I will think it could be disaster. And this is what happened. We declined this offer because unknown cause of death or no confirmation of cause of death. Both recipients, transplanted into 2 recipients, died of meningitis. What happened? Autopsy showed this parasite. So it was parasitic meningitis, and the center hit the news. It was a scandal, national scandal, and The Guardian. 2 young recipients received parasitic kidneys and died. Because rule number 1 in cadaveric transplantation is known cause of death. Suspected, I can't buy it. I won't buy it. Confirmed, yes. So clear guidelines regarding the suitability of brain-dead patients for organ donation, because the center broke the rules. Number 1, as I mentioned, this donor had parasitic meningitis, never came to our mind. Fine, so another disaster we've been through, and this is actually, you will see this actually in deceased donor transplantation, cadaveric transplantation. You have to expect a lot of surprises. You were offered a kidney from a 49-year-old male DCD, donation after circulatory arrest, who died of progressive lung fibrosis complicated by hypoxic brain damage. Baseline creatinine was excellent, 68 micromole per liter before retrieval, 81 just before retrieval. Urine output 133 mL last hour, last 24 hours, 3.1 liter. 1+ of protein, no hematuria, no blood in the urine. The kidney was offered to CKD2 patients, one of them 51, 111 mismatch, another one 64 was 120 mismatch. In Sheffield, we used to do a post-perfusion biopsy. And the post-perfusion biopsy showed query metastatic lung cancer in 1 kidney. So the protocol biopsy, one of the kidneys showed evidence of metastasis from the lung. What would you do? We didn't know the answer. We kept asking other centers, and we have a consensus between all centers in the UK. So what do you think? What would you do? Biopsy of one kidney showed cancer coming from the donor. Shall we carry on, keep the transplant, reduce immunosuppression, give immunosuppression, do what?
Remove the kidney. Graft nephrectomy.
Follow up and reduce immunosuppression. But immunosuppression is immunosuppression. I appreciate this. This is one of the options we were offered, but we didn't take that one. Because immunosuppression is still immunosuppression. Any other option, any other opinion? I will tell you what we did. I don't know whether it's right or wrong, but both patients survived and retransplanted. We removed both kidneys. And we sent them for histology. Both kidneys were stunted with lung cancers. So the biopsy in 1 kidney showed lung cancer. The other kidney, because of the sampling error, the biopsy didn't hit the cancer cells. One of them transplanted, 2 transplant afterwards. So what we did, this is actually a transplant nephrectomy for both patients. Fine. The fourth scenario,
صح كيف نقول
Chairman, please, you just stop me if. Yeah, fine. You were offered a kidney from a 71-year-old DCD, donation after cardiac death, who suffered subarachnoid hemorrhage grade 5, not amenable for any surgical intervention, blood pressure well controlled on one agent. He had mild diabetes, diagnosed last year. Excellent kidney function, creatinine was excellent, it's 81 micromole per liter. But because this was 2 o'clock in the morning, 3 o'clock in the morning, we didn't have any records of microalbuminuria or fundus examination, because this actually would be in the GP records. 2 o'clock in the morning, we don't have access to the GP. So we have to go ahead and transplant. Will you accept this donor?
Yes.
Yes, yes, yes. Fine, great. How would you transplant? Non-diabetic recipient. Rule number 1, yes, non-diabetic recipient. But
Small
you know,
size.
71 with diabetes, you don't have any information about the microalbuminuria. If there's any diabetic nephropathy, we don't know. Sorry.
Maybe to give to older individual rather than giving it to a young man. No, to an older person.
Sorry, I can't.
So
tell.
give this kidney to an older person rather than to a young man.
Okay, fine. So what we did, because we didn't know whether diabetic nephropathy is there or not, because lack of information. This is actually what will happen with a deceased donor transplant. We put both kidneys together and biopsied them. Severe diabetic nephropathy in both kidneys. Not only that, with the McFree scan, the top kidney ate 20% of the function. So the top kidney was absolutely naked with diabetes. So I'm just trying to introduce the concept of dual kidney transplantation in marginal donors, expanded criteria donors. Try to accept as much as you can, maximize the nephron mass by putting both kidneys together. Fine. So another interesting scenario, this donor was rejected by other centers because of the kidney function, eGFR 50 to 60 mils over the last few years. This is a GP record. So it was declined by another center. How would you accept? Will you accept? Will you transplant? And how? Just to cut the story short, you have a 61, so expanded criteria donor with low eGFR, bilateral kidney transplant. Use both kidneys. Try not to waste them. Why both kidneys? Because the allocated recipient was 67. So less likely to have another offer in her lifetime, number one. Number two, it's a lot easier to do bilateral rather than dual. 2 teams can do that. And this is what happened. I did one side, and my team did the other side. Fine. A small recipient, a small donor with very small kidneys. When I retrieved both kidneys, I found the weight is quite very light kidneys. One of them is 62 grams, and the other one 71 grams. The normal weight, usual weight of a kidney, healthy kidney, is around 150. How would you manage? Small kidneys. Dual. Look, I'm giving you a lot of dual kidney transplant today. Fine. Interesting case. This case, after retrieval, we found this lesion. Biopsy, actually, it was excised. Came back as clear cell carcinoma, grade 1. But the margin was not clear. So I went back again and removed the bed. The computer, which does not think, automatically allocated this kidney to a highly sensitized patient, 97% CPRA. Will you accept this kidney with a hole in the kidney to this highly sensitized, and it's a cancerous kidney? But however, cancer was removed completely. Safety margin was clear after re-excision. To cut the story short, this form of kidneys are transplantable, but there are certain criteria should be fulfilled to transplant the kidney with cancer after removing the cancer. Should be non-sensitized elderly patient and to give sirolimus. Of course, the recipient, potential recipient allocated by the computer is highly sensitized, so you cannot give sirolimus here. We couldn't find a suitable donor. We offer the kidney nationally. Couldn't find a suitable, sorry, we could not find a suitable recipient. We discarded. There's extensive experience we got from Newcastle where they transplant partial nephrectomies following cancer treatment with whether segmental or non-segmental. So these kidneys are transplantable. Fine. This is an easy scenario. An offer in the middle of the night from a recipient, from a donor who had breast cancer treated recently, finished treatment 8 months ago. Stage 3, chemo, radiotherapy, sampling, and the offer for any recipient. Will you accept? However, there is allocated recipient, but we rejected for this recipient. Will you accept? So this actually stresses the importance of guidelines here. Breast cancer should be minimum 3 years of complete clearance of cancer. However, personally, I will accept any donor of history of breast cancer because breast cancer can come back even after 9 years. Fine. Another donor confirmed meningococcal meningitis.